Okay, so in today's lecture, we'll be talking about what is obesity and why should we address it, which is the most important thing, and how much should we lose, and how to achieve it, and how to maintain. Obesity. So, according to the World Health Organization definition, obesity is abnormal or excessive fat accumulation which presents risks to health. So I want all of you to pay attention to these keywords: abnormal fat, excessive fat, presenting a risk to health. Okay, so what is abnormal fat? So it's mainly belongs to abdominal fat. So we can get an idea about the abdominal fat with the waist circumference. However, the gold standard is to get a CT or MRI where you can have the cutoffs. However, routinely we don't do that. So this is about central fat. So what is excessive fat? If you take a male, total body fat of more than 25% is excessive. And for a female, more than 33% is excessive. So these cutoffs are usually taken with body composition analysis, usually the DEXAs. However, in our local setup, we can do bioelectrical impedance analysis and use these methods to assess the body compositions. So we talked about abnormal fat, we talked about excessive fat, and lastly, so let's see what are the risks. So if you can see, the risks can be metabolic, mechanical, and psychosocial. So we all know that the insulin resistance, diabetes, cardiovascular disease, non-alcoholic fatty liver disease, and cancer as well. So all these metabolic risks and mechanical, mainly the osteoarthritis and obstructive sleep apnea, and psychosocial, the depression and social stigmas. All these are risks which is to our health. So this is the basic, understanding we have to have, the definition that we have to know about the abnormal fat, the excessive fat, and what are the risks offered with the obesity. Okay, so the central fat. So waist circumference in clinical setting, this is the most important measure, I would say. However, it gives independent risk information which is not accounted for by BMI. It means, say that we all talked about the metabolic risk. If you have increased waist circumference, even with a normal BMI, you have increased metabolic risk. So this is the most important thing. The one point is population dependent. WHO says, high waist circumference is more than 88 centimeters for a female and more than 102 centimeters for a male. However, we use International Diabetes Federation, the IDF cutoffs, which actually comes with our local data as well. So according to that, more than 80 centimeters for a female is, we consider them as having increased waist circumference, and more than 90 centimeters for a male, we consider it as increased waist circumference. The most important thing is, as Asians, we have at a lower BMI, we have a higher fat percentage, so we have risk of getting increased metabolic diseases. So this is really important, measuring waist circumference in every patient that you get. Okay, so this actually shows the multifactorial nature of obesity. You can see the unfavorable genotype, the sedentary behaviors, lack of physical activities, and then comes the unhealthy dietary habits, and here the alcohol and all the stress. So this leads to obesity, central fat as well, and you can see it alters your lipid profile, hypertriglyceridemia, all of this, and inflammation, affect the insulin resistance, endothelial dysfunction, and ultimately you have the metabolic risks, having cardiovascular diseases. As you know, it is the main killer of obesity. Okay, the BMI. So we all know that BMI correlate with the degree of fatness. We talked about the total body fat as the cutoffs. So it's good as a screening tool, especially in the population level. However, you know that it's the data usually derived from white Caucasians. As I said earlier, the South Asians have a higher fat percentage for a given BMI. So we need actually, separate, cutoffs. So because of that, WHO proposed in 2002 several cutoffs. However, they didn't, change the overweight obesity cutoff. They just included these, the 23 as overweight and 27.5 as obese. That is, take actions at the population level. However, in 2009, Indian experts led by Anup Mishra, they actually came to a consensus recommendation to take overweight cutoff as 23 and obese cutoff as 25. And Sri Lankan data, current Sri Lankan data, we actually are going towards these cutoffs currently. Okay, this is a recent trial done by Prof. Rani Javadana, and you can see this data also confirms that what we talked about. However, you can see the data are even alarming. You can see a BMI of 23 corresponds to a body fat percentage of 25% in male and 35% of females. So this is actually the obesity cutoff, if you can remember. However, you don't have to worry about whether you are overweight or not. However, just remember that we have increased metabolic risk factors even with a lower BMI. So the take home message is, if your BMI, let's say if your BMI is over 23, it's high time that you get your metabolic complications screened. Okay. So why should we address it? So obesity is, fortunately, it's modifiable through lifestyle interventions. However, that's a certain extent. Like if the BMI is more than 40, it's kind of lifestyle interventions are not that successful. However, up until 40 BMI of 40, we can use it. So if we modify it, we can have these benefits. Like you can have all these metabolic benefits, mechanical benefits, and even the psychosocial benefit as well. So, and the benefits are intergenerational because these affect the impact on childhood obesity. You can see for the next slide, I'll be talking about that. So if you can go through this article, leisurely, this is the Field for Diabetes study, and you can see that this bar chart, it shows the children's weight status by parental obesity. Here you can see three phases, like three groups. The first groups, you can see both parents are non-obese. Second, at least one parent is obese. And third, both parents are obese. So it says, when both parents are non-obese, you have 80.4% of the children are either normal or weight. So for the time being, let's say it's normal, okay? And you can say 15.2% per overweight and 4.4% per obese. So when we go to the next group, you can see at least one parent is obese, 23.7% per overweight and 11.8% per obese. And lastly, when the both parents are obese, you can see 27% overweight and 27.2% obese. So when you take it together, more than 50%, you can see more than 50% of the children are obese. So if you can break the cycle, say that you can come from, from both parents are obese to at least one parent obese, you see the normal percentage will be 64.5%, and here the 45.8%. So that's why, I think you can understand the importance of this. If we can break the cycle, we can revert from third to second to and first category. Okay, so how much to lose? Current obesity guidelines recommend usually 5 to 10% weight loss over 3 to 6 months. However, even a 5% weight loss, even a modest weight loss can give you clinical benefits. If one can achieve, more than 10% weight loss, it's possible, some of the diseases like, obstructive sleep apnea, type 2 diabetes, those kind of diseases to go into remission. Mind you, this is grade A evidence. I think these, DM remission, this topic was talked in last month SLSLM lectures. Okay, so we talked about what is obesity, why should we lose weight, and how much to lose, and let's say how to achieve it. So there are several components, and if you see several components for a problem, you know that it needs a multidisciplinary team to address the issues. I would say the most important fact is the first one, that is, the readiness to change. If a patient does not see obesity as a problem, whatever the advice that we give or the intervention that we do, I don't think that it will work. And diet, this is the most important thing that we're going to talk today. And the physical activities, I talked to Samantika as well. I think we need a separate lecture on this from a sports medicine specialist. And so other than that, we have to address the other factors like stress-related binging, sleep. Main reason, so main reason, even insufficient sleep, it can affect gut hormones. That ghrelin is the hormone that increases our appetite, and it has shown that reduced sleep can cause increased ghrelin and lowers the leptin, which is our satiating hormone. Okay. So the current obesity guidelines recommend continuous energy restriction as the first line therapy. So this is actually a stepwise approach. You can see you start with reduced energy diet, go on to low energy diet, then the very low energy diet. Of course, you can break the order depending on the individual patient. However, this is the usual algorithm. And there are various diets. Actually do not want to talk about this. However, we'll touch a bit about these things as well. Okay, right, the reduced energy diet. So this is the first line. As I said, it's simple and effective. It's kind of a balanced diet. It's provide 50 to 60% of protein, carbohydrates, and usually the 10 to 15% of protein, and 25 to 35% of fat. What we usually do is we get 500 to 1000 calorie deficit from the basal requirement. So this comes to around 1200 to 1500 for a Sri Lankan woman, and 1500 to 1800 for a man. So if you do this, you can easily achieve 2 to 4 kilogram per month weight loss. This is what we do. This is kind of a general advice. We'll see later, and this is non-prescriptive, so it will improve the compliance. Okay, I actually included this slide because people ask why this 500 calories, why not 600, why not 700. So if you can see, usually 1 gram of fat, it gives you 9 calories. And when it comes to body fat, 1 gram of body fat gives you 7.7 calories. If you can see, so 500 grams body fat means 7.7 into 500 grams, 3,850 calories. So if you want to reduce 500 grams, you have to cut down 3,850 calories. So if you are to reduce 3,850 calories over 7 days, then comes the 500 calorie day reduction. So that's how you know that.
Excuse me, Dr. Damith.
Yeah.
I think we should emphasize on this slide. Actually, this is the kind of calculated depiction of how we do diet plans. So I think participants should pay special attention to this slide. This is how you explain why are we just cutting off 500 kcal per day. I think this is a very important slide, I suppose.
Yeah. Thanks for reminding me, Aruni. So then I will re-explain it. So this is, you can see this is normal fat. So 1 gram of normal fat gives you 9 calories. However, the body fat, it does not only contain fat, but water and other stuff as well. That's why it gives less than 9 calories. So it's bomb calorimeter predictions, they give like 1 gram of body fat contains 7.7 calories. So as I said, 500 grams body fat gives you like 500 into 7.7, 3,850 calories. So if you are to reduce 500 grams of fat, you have to cut down 3,000, this amount of calories. If you are to do that on over a period of 7 days, that's how that 500 calorie cutoff has come. So I think I hope that you understood. Okay.
Yes.
So for me, I think. Hello. Yeah.
Sorry.
For me, I think.
Sorry.
Okay. For me, I think this is the most important slide in my lecture, the quarter plate model. That is how to achieve that reduced energy, the rate that we have been explaining in last few minutes. So I would say you can use the same plate that you are currently using, and you have to. So this is carbohydrate. You serve carbohydrates to a quarter of your plate. So this is the quarter of your plate. So be it, be it rice, be it pasta, be it noodles, be it legumes, and be it starchy veggies like let's say jack curry, let's say potatoes, let's say sweet potatoes, manioc, whatever the carbohydrate containing food source, it should be within this quarter. And one more important thing is, if you are, let's say, if you're using 2 carbohydrate food sources, let's say you use rice and a potato curry. So can you see this dotted line? So if you serve potatoes, you just serve it here like this, and you have to reduce the rice to this portion only, because what we have, what we are used to do is we usually serve rice, and on top of rice we used to serve the other food. So from now on we should not do that. So every we are taking carbohydrate food options, whatever the amount of number of carbohydrate food options that you have, that should come inside this quarter. Okay, I hope that you can understand. And what about the others? Like if you are taking bread, so let's forget about rice meal. So if you are taking bread, string hoppers, those kind of things, what would you do? So the simple advice I usually give to the patients is, so let's say that if you have been eating 15 string hoppers, reduce it to 7. That is 50% of what you have been eating. If you take 4 hoppers per meal, you reduce it to 2. If you eat 2 rotis, 2 doses, likewise, whatever the number that you are used to eat, reduce it by 50%. So it's really simple, and I think it's doable. So that is what you have to remember. So we talked about starch, and then comes the protein. So we encourage animal proteins and vegetable proteins as well. So animal protein, we encourage fish, eggs, seafoods, fats, lean meat. Usually lean meat, because we discourage frequent use of red meat, because it is and red meat and processed meat also, because red meat plus processed meat are group 2A carcinogens according to the IARC, the International Agency for Research on Cancer. I want all of you to go to the International Agency for Research on Cancer website. There they have an interesting summary which is given as a question and answer form. And so as vegetable proteins also, we can use soy products like TVP, tofu and all this stuff. However, there's one more point that I have to stress. If you're using, dal as a protein source, we all know that dal is a legume and it has carbohydrate as well. So it also, you have to, serve it for a 50% of this quarter of this plate. So not the whole quarter, but 50% of this quarter. Okay. So we talked about carbohydrates, we talked about the proteins, and the other half then comes the vegetables. So if you have, let's say, 2 veggies, you fill it with 1 and 2 likewise. If you have 3, which is better, so you serve it for equal amounts, 3 veggies. So this is the, as I said earlier, this is the most important slide. So if you have any questions, I can actually go through it again. Okay, I hope you understood. Okay, so we talked about the composition. So there are few more tips, like there's evidence that chewing can alter gut hormone response. So it can make you feel satiety. So be mindful about this when you're having meals. So one small tip is when you achieve, when you start eating, you can start with proteins or veggies. Say that you have 2 to 3 pieces of fish, and you start, you first start eating the fish. Let's say you eat 1 fish and you go on to eat some veggies, and then go on to have rice. So this actually, really helpful, get the satiety, which is really helpful. And even if you're not obese, I want all of you to try this method, and if you feel more satiety, and if you can let us know, that will be really nice. Okay, so little bit more about about the good practices, like try to have more family meals, not television or phones or tabs, because ultimately what we are doing is a behavioral change. That is the most important thing. Okay. So if you're hungry, say just after a meal, okay, you're feeling so much hungry, so you can serve again, but only the vegetables or protein option, not the carb. So with that, you can have a satiety, which is really important, so that it improves the compliance to the red diet. And if you are, say that you feel hungry later in the day, so we then encourage low calorie fruits, veggies, or tea or coffee. And for the low calorie fruits, I think it's better to have local fruit varieties like umbrella, rose apple, guava, veralunelli, those kind of things, because they have less calories. Okay, so okay, the tempering. This is also really important. We encourage to use monounsaturated fatty acid oil for tempering. You all know that there are 3 types of fat: the saturated, the unsaturated, and the trans fat. Saturated and trans fat are the unhealthy fats. So that's why we have cutoff, like We have to have less than 10% of fat from the saturated and less than 1% from the trans fat. And from all of these, the monounsaturated fats are the healthiest because there's evidence that it reduced total cholesterol, reduced triglycerides, reduced LDL, as well as it improves the or increase the HDL levels. So for tempering, you can use olive oil, canola, or ginger. Olive oil is a bit expensive, so canola is relatively cheap, so you can go for canola. Or if you can, you're okay with the taste, you can go for ginger oil as well. Next thing is, you have to, when the patient comes, you have to take a food reconstitution and identify the unhealthy dietary habits and address these, avoid all meat, energy dense snacks, these unhealthy dietary habits as well. So most important thing, as I said, the compliance is the key. So if you can adhere to this method, it's really possible that you can get at least 2 kg weight loss during 30 days, the 1 month. Okay, so we talked about the diet. Next is the physical activity. So as I said earlier, it's high time that we get a lecture from the sports medicine specialist. However, just to touch on this, have to be physically active. The recommendations are 150 minutes a week. That is usually 30 minutes a day for 5 days of moderate to vigorous physical activity to start with. The more is better. And 3 days a week strengthening exercise. This is really helpful to increase energy expenditure. And there's growing evidence that combining healthy diet as well as exercise, it promotes the diversity of our gut microbiome, and it contribute to the weight loss. Okay, so in our setup, what we do is we refer them to sports medicine unit, because most of the people they have severe osteoarthritis and back pains and stuff. So they usually cannot go ahead with regular physical activities. That's why we need for them to have individualized exercise regimes. And then we usually review them in 1 month period with a food diary and these basic investigations. You have to assess your metabolic risks, and not to forget the vitamin D level, because we have seen most of our obese patients, they have either vitamin D insufficiency or vitamin D deficiency. So if it is there, we usually start with vitamin D stoss therapy and followed by the maintenance therapy. Okay, so we talked about the red, or that is the reduced energy diet. Then we come to the lead, the low energy diet. So if the target weight loss is not achieved, this is the next step. However, if you come to this step, you have to really motivate the patient. That is really important. And then as it's shown here, it's usually 1000 to 1200 calorie diet. However, we usually go for 1000 calorie prescriptive diet. This has to be prescriptive. The important thing is you have to tell the patient what has to be taken for main meals, what has to be taken for snacks, the time, everything has to be prescriptive. If the patient can afford, you can really incorporate commercial meal replacements, which usually provide 200 calories and 20 grams of protein. And you can use, and it's better if you can use NutriSurvey, NutriSurvey software, so that you can analyze the food composition and give a specific food plan. This is just a sample. This is a free software actually. You all can. I have included the link to download it, as well as the food databases. You can download this software and you can analyze. You can analyze. Yes, you can analyze. The most important thing is we have country-specific food databases. However, we don't have one for Sri Lanka, but we can use Indian one, and use the USDA food database as well, because it gives a lot of information. You can see, it gives the energy, how much of energy that is there in the meals that we have input here, and the protein, the fat and the carb, everything. And if you go to the 8 percentage, you can get the RDA levels as well. So if you go for 1000 calorie diet, you can analyze the micronutrient levels as well. So if any of the micronutrients are deficient, we can start early micronutrient supplementation as well. Okay, so those are the main things that I want to stress on, and then come the VLED, the very low energy diet. This is usually done under medical supervision, so I'll just run through. The indications are if the red or the reduced energy diet or the low energy diet is unsuccessful, or else if you need a rapid weight loss, let's say you need to prepare the patient prior to a bariatric surgery. So this we can use this. Usually, it provides an 800 calorie or less diet. There are two types of VLED, complete VLED and partial VLED. The complete VLED, we replace all three meals, like we use 3 commercial meal replacements plus non-starchy vegetables in between. In partial VLED, we use 2 commercial meal replacement, that is we replace 2 meals, and we provide a 1 meal which gives about 200 to 300 calories. This usually consists of vegetables, lean meals, and a bit of monounsaturated fatty acids. Usually this is low in carbs, so it induces a mild nutritional ketosis, that there is evidence that it has an anorexic effect, so the compliance would be good. Okay. So as I said earlier, this is being done under medical supervision, and baseline investigations have to be done. The electrolytes, creates, transaminases, all this stuff, and they have to be repeated every 4 weeks, because this usually goes on for like 2 weeks, 12 weeks period. However, it depends on the target weight loss that we want to achieve. And if there's, severe electrolyte disturbances such as hyperkalemia, or if there's anemia, you may consider discontinuing. Okay, so this is a therapeutic diet. So as a therapeutic option, this has contraindications, and elderly more than 65 years, and recent cardiovascular disease, surgical disturbance, alcohol or drug abuse, all these things are contraindicated for VLED. So the most important thing is, even after we starting VLED, we have to know whether it's responding or non-responding. So if the weight loss is 1 to 1.5 kg a week, we know that the VLED is responding. And if the weight loss is less than 1 kg a week, that is for consecutive 4 weeks, we consider it as non-responding. So if it is so, we have to assess the compliance, and then if the compliance is good and the non-responding, we have to consider pharmacotherapy. And for responders, so once the weight target is achieved, we should not, stop it immediately. It has to be weaned off, because if you restart regular diet, there will be a rapid weight gain due to metabolic adaptation. So what you do is you introduce 1 regular meal at a time. Let's say that the patient was on 3 commercial meal replacements, so you introduce 1 regular meal and continue the 2 the commercial meal replacement for 4 weeks. So likewise, you have to wean it off. Okay, so the monitoring has to be done. It has to be done monthly, and it says that up to 3 kilogram weight gain is physiological because of the metabolic adaptation. And they say the intermittent VLEDs, that is 2 weeks every 3 months with a commercial meal replacement, has to be done until the weight is stable. And if there's more than 3 kilogram, so then you have to restart VLED with pharmacotherapy, or else if it is not responding, the ultimate option is bariatric surgery. Okay, so those were the main stuff that I wanted to tell. Diets. Actually, I didn't want to talk about other types of diet in this lecture, because we tend to forget important stuff or popular stuff. Anyway, so just to have a rough idea, when you analyze types of diet, you have three variables like the composition. You can manipulate the composition of the diet. You can either manipulate the food groups or manipulate the timing. So these are the three main variables that you can manipulate on when you go for a diet. So you can see the macronutrient manipulation. You can see carb can be reduced like in Atkins and keto, and the fat here, yeah, you can see the fats can be increased like in keto, and proteins either normal or increase. So this is mainly the composition variations are mainly on reducing carbs and increasing fats. Sorry. Then the food groups. Yeah, so the Mediterranean diet. So it's so this is rather than a type of diet, this is actually a eating style. They encourage eating whole grain cereals, legumes, fruits and veggies, the nuts and seeds, and their main oil source is olive oil, and they prefer fish and seafood over animal proteins, and they use dairy products in moderation. And there's evidence that it reduces cardiovascular risk factors and overall mortality. And if you closely see, we can incorporate this easily into our quarter plate model. If you can remember that, that quarter plate, the carbohydrate, we can incorporate that whole grain cereals or the legumes to the as the quarter plate model, the carbohydrate part. Then the vegetables come to the half of that. Fruits, nuts and seeds, they go into snacks. Olive oil would be, as I said earlier, this would be the tempering main source of oil, and fish, seafood and the lean meat as the protein option. So you can see, that's why I said this is rather than a type of diet, this is kind of a eating style that we can incorporate to our reduced energy diet or the quarter plate model as well. So just a bit about DASH. It's the name denotes as dietary approach to stop hypertension, which was actually introduced to control blood pressure. So it has limited food groups which has high sodium and saturated fat as well as added sugar. Okay. Intermittent fasting, I would talk a few slides later. Okay, so the important question, is there an optimal diet for weight management and metabolic health? So there are numerous reviews, numerous meta-analysis. However, the conclusion up to now, the conclusion is, with regard to the weight loss, none is superior to each other. That is the main reason why still the obesity guidelines recommending reduced energy diet as the first line therapy. And they say weight loss improves almost all obesity related comorbidities and metabolic markers. So that's why some says that if you use low carbohydrate diets, there's it's possible that you can reduce more triglycerides. Yes, but if you have if you can have a considerable weight loss, all the lipid abnormalities will be improved. So that is regardless of the macronutrient composition, you will get all these metabolic benefits. So that is why they say optimize the adherence. So this will give a successful weight loss. Okay, intermittent fasting. I thought of adding few slides because I met few doctors currently practicing intermittent fasting. yeah, this is for few, it depends on the individual, it's kind of useful, if a patient, let's say, cannot, continued energy restriction, the red diet, as we talk, due to, busy lifestyle way. Say that, you have kind of theater list for 2 to 3 days, and, endoscopies do likewise, starting from the morning and, go on, until the evening. So if it is so, you can actually go on and, try this. So there are 3 types mainly. You can see the alternate day fasting and the 5-2 diet and time restricted feeding. So what you do in alternate day fasting is you get a regular diet in one day and followed by in the following day you fast. So during that fasting day, you can take up to, food up to 600 calories. So that's why, sometimes, you can take this 600 calories as a one meal, or else, divided throughout the day. So it just, it depends on your choice. And the 5-2 diet, so fasting for 2 days with normal eating for 5 days. However, the important point is this fasting 2 days should not be 2 consecutive days, because there's risk of hypoglycemia. So yeah, and the time restricted feeding, we all know this is kind of most popular, among the doctors. This is 16 hours fasting and 8-hour feeding. So during fasting period, you can take tea, coffee, without sugar, and as well as water. So this is the basic idea of intermittent energy restriction or intermittent fasting. Okay, just to add few evidence. So you can see the research question is alternate day fasting more effective for weight loss and weight maintenance, which is compared with daily calorie restriction. You can see the conclusion. It says that alternate day fasting diet was not superior to the daily calorie restriction with regard to adherence, weight loss, weight maintenance, or improvement of metabolic risk. So that's why I said still the obesity guidelines recommend reduced energy diet or the continuous energy restriction as a first line therapy. So another review: to do intermittent diets provide physiological benefits over continuous diet for weight loss. Conclusion: intermittent fasting is valid. That's why I said it's valid. However, not superior to continuous energy restriction for weight loss. Another meta-analysis: intermittent fasting versus continuous calorie restriction, which is better. This is actually a recent meta-analysis. Here you can see there's a significant body weight, and the standard mean difference is 0.21. P-value is less than 0.05. So that's a little bit significant. However, you can see there's no significant difference between the BMI change. So the conclusion is maybe superior for weight loss in some respect. So that's why I said, the new trials are coming. So we will see, the evidence in near future. For the moment, still the first line therapy for most will be continuous energy restriction. Okay, I actually deliberately included this slide because, as I said, this is the most important slide in the lecture. So don't forget carbohydrates, quarter of your plate, proteins, quarter of your plate, veggies, half of your plate. And the other important thing, you start eating from proteins, veggies, and go on to carb. Okay, thank you. I think we have like 15 minutes for the questions, I think.
So Dr. Damith, they would like to know the pros and cons of intermittent fasting. Maybe they are practicing and they would like to know further. Can you please elaborate on us on the intermittent fasting, please?
Yeah, as I said earlier, from the evidence that we have, nothing is superior. So intermittent fasting, I can't say that it's a first line therapy. However, the process is, if a patient, say, depending on your lifestyle, if you can, if you cannot maintain the reduced energy diet or the continuous energy restriction diets, yeah, so depending on that, you can choose it. However, know that it's not superior to the first line recommendations that we talked about. The cons, it depends. Usually they say there are minor side effects like, halitosis, keto headaches, and GERD, worsening of GERD symptoms. If you can, tackle those, and usually those are short term actually. If you, continue the diet for like 1 to 2 weeks, those minor side effects should go away. So yeah, so those are the main things I would like to, highlight.
Okay. Another one, they want your opinion on a diet which is very popular these days, containing high fat and protein diet without any veggies. There's a popular diet these days. So they would like your opinion on that high fat and high protein diet. Hope.
Yeah. So if you have if you have been listening to the lecture, all these fad diets, the definition of fad diets is it just it just give you something that I would say a rapid weight loss. So those kind of promises are there. So but the evidence is still not there. So if you want go for a diet, just don't go for popular diets.
Yes.
Just assume, assess whether it's, practical for you, because still, the evidence are there for continuous energy restriction, because none is superior.
So in that case, the take home would be that should be balanced with reduced energy. As far as whatever the diets which are becoming popular time to time will all be therapeutic and not good for a kind of long-term use. Hope so.
Yes, the most problematic thing of the popular diet is the company. You can't practice it for a longer time. That's the main problem with those things.
Right. So they would also like to know about commercially available meal replacement in the country.
Yeah, we have several meal replacement. I don't know whether it's okay to tell the brand names, but but we have them, and usually one provides like 200 calories and 20 grams of protein. According to my knowledge, there are two companies.
So you can go to the nutrition profile and read that low calorie and adequate protein, then that will be, they are available, right?
Yeah. Yes, because if you say that if one is going to go with a very low energy diet, usually 800 calories a day or 600 calories, let's say. So if you want to replace your 3 meals with commercial meal replacement, as I said, the currently locally available meal replacement products, they give you 200 calories and 20 grams of protein. If you replace your three main meals, you can get 600 calories and 60 grams of protein. And in between, if you can use veggies and stuff, you may go for 700 to 800 calories adequate protein. So that's the main thing.
And also, can we have some of your opinion on the paleo diet, which is kind of
the caveman diet. Yes. So as I said,
that goes with this lifestyle medicine a little bit. That's why we are asking about it, because it's more with natural food, lot of natural food, and so kind of.
Yeah, but if you analyze the composition of the paleo diet, if I can remember, it's also a type of moderate fat, high protein diet, and it restricts, the whole grain and stuff because, because of the caveman type. So again, what I want to specify is, just don't go for a popularity of diets. Just, be simple. If it is, practical or compliance with you, just go with the first line therapy.
Yes. Also, just a simple clarification about oil. The tempering and what are the good oils for tempering and deep frying with regard to cholesterol lowering. Can you please explain us about that too?
Yes, we talked about a few info about that. However, for deep frying, the coconut oil is the best because it's a saturated fat. So there's less risk of, making of trans fat as it's a saturated fatty oil. And for tempering, the monounsaturated fat or PUFA, the polyunsaturated fatty acids are the best ones. So as names, olive oil, canola, and gingerly are the monounsaturated MOFA oils that we have, and sunflower and other soybean, those are PUFA oil. So I would recommend, you use monounsaturated fatty acid oil, such as olive oil, canola, or ginger oil for tempering, and coconut oil for deep frying.
With the portrait model that you have just explained, we have another question for you with regard to rice, which is limited to 1/4 now by you. So, difference between white rice, parboiled rice, red rice. Can you just explain the benefits over these rice with weight management?
Yeah, usually we don't, specify on specific types of rice. However, I think you can remember about the Mediterranean diet where they, emphasize on having whole grain rice. So if you can go for parboiled rice, yes, that's better, and even the red rice, it's better. However, the polished rice contains less micronutrients than the whole grain product. So yeah, if you can go for those, parboiled or red rice, which is not polished, they would be better in a perspective of micronutrient composition. However, with regard to weight loss, because the question was about weight loss, there's not much of a difference, I would say. The main thing was, if there is, the parboiled and the red rice, if it is not polished, they have more fiber. So if there's more fiber, you tend to chew more. And you can remember that I had a slide. If you chew more, there's more of ghrelin and
Satiety.
Yes, the satiety is the thing. So they are, it might help you, but so it's depends on your choice.
Yeah. So all these convert into this lifestyle medicine. The first pillar, the whole food. The whole food will be always good. That's what comes through that, the answer of that question also. So, will diet cause a change in BMR? So that's...
What do you mean by right?
So that can cause the diet-induced thermogenesis, I suppose, but that's how
usually BMR, basic metabolic requirement.
They want to know whether the diet causes any changes in BMR as far as the metabolism is not disturbed. I don't think it does.
Yeah, but there's a point, like let's say one diet courses, one diet courses you would have weight loss. So if the weight is losing, of course the BMR will be low.
In the long term, that can cause change in BMR, isn't that so?
Yes. So that is when you go with the longevity studies. So there is evidence that There are few parameters that they use to talk about the longevity, the basal requirement, the core temperature, fasting insulins, and all those stuff. I can't remember the other stuff. However, when the core temperature is low, that is the BMR is low, there's evidence that the longevity is more.